Welcome, welcome. Hello, everyone. My name is Rocky. I am a case manager with ACRC Global at our New York office. I'm working from home today, but I'm always at the New York location, Monday through Friday. Okay. And of course, I'm joined by the amazing Dr. Park, who works at SDFC. She is going to give us some information about where she is in her IVF clinic, the process, some rundowns, some details. And of course, as we go through the process here today through this webinar, we also have a raffle that will be happening at the end. We have some submissions that have come in, but please feel free to scan the QR code that's going to pop up and fill out the application. I'm going to go ahead and swipe down here very quickly. You can just scan that code, fill out the form, and at the end of today's session, we'll go into the raffle and pick our winner, who will win an additional $1,000 credit to the process, because we know, of course, things happen, prices are unexpected, fees, all the things, right? So we just want to provide a little bit of help during this process, okay? Now, of course, I will pass the baton off to Dr. Park to explain a little bit about herself, her background, her amazing expertise and knowledge. And then she will go into her presentation and go from there. So take it away, Dr. Park.
Thank you, Rocky. So thank you to all of you who've taken the time to join us for our webinar. We are always so excited to talk about what we are passionate about, right? Which is helping you grow your family through egg donation and surrogacy. So a little bit about me. I was born in Korea, and immediately my family moved to Buenos Aires, Argentina, where I lived for a number of years. And then when I was 6, my family moved to New York. And I lived in New York for many years until 2012 when I moved to California. So I'm a New Yorker at heart, like Rocky. So I've been doing this 20 years. When I was in New York, I worked at Columbia University. But at that time, surrogacy was actually not legal in the state of New York. It's recently changed. So coming here to California about 12 years ago, we did a lot of egg donor and surrogacy. And through that, we've gained a lot of experience. And one of the things I've learned is just how confused people are about the process. So I really hope that by the end of this session, you at least have a good framework of how to simplify this egg donor surrogacy journey. So let us proceed. So I'm going to share my screen. All right. So let's start with our clinic. So this is our clinic. We have a number of centers, but this is the mothership of our clinic, which is located in San Diego, but in a part of San Diego called Del Mar. It's a standalone building. It's 2 stories. It's really beautiful. We are building another standalone building in Mission Valley. And most of you know where San Diego is, but for those who don't, it is a beautiful beach town with just a great weather. And there's a big naval presence here. So it's a great town. So let's divide the process into 3 parts, because it's really important to simplify and organize. So step 1 will be sperm. Step 2 will be creation of embryos. And step 3 will be transfer into a surrogate. So let's go over each step one at a time. Sperm. So you would do a sperm test and blood test with your doctor in your own hometown. We would just give you a requisition for it. Once we review it and make sure it looks okay, you have to then do the whole thing again. But this is the real deal, the real sperm we're using for the treatment. Now, the FDA, Food and Drug Administration, says that when you get eggs and sperm to create embryos to put in a surrogate, we have to really protect the surrogate and make sure we don't inadvertently give her an infection. So the FDA says at the time you get the sperm, at the time you get the egg, there are specific infectious diseases that must be done around that time. And these tests must be sent to a special FDA lab. So you cannot do that with your own doctor in your hometown. So there are special places where you can go. So we have a place in New York where you can give them your frozen sperm. They will then do all the mandatory FDA tests. They then ship the sperm to our facility in San Diego. Alternatively, you can decide, we're going to go visit the clinic, so you can come to our center to freeze your sperm, and we will do all the mandatory FDA tests. Once we have your sperm, your presence is not needed. So a question I get asked a lot is, my gosh, but I live in Florida. Why would I go all the way to a clinic or an agency in California? Because we just need your sperm. And once we have your sperm, the location of your clinic really doesn't matter as much. All right. So step 2, creation of embryos through a process called in vitro vitro fertilization, IVF? Well, to create embryos, you need an egg donor. So ACRC will help you match with an egg donor. They will give you some profile. And once you know who your potential egg donor is, our job is to make sure she's medically healthy. So there are some egg donor criteria, and this is just general rules. So one is generally we want her in her 20s. Now, I've made exceptions for egg donors who are 30, 31, just because her numbers look amazing. She needs to have a good ovarian reserve. That is, she needs to have good egg test results. Her family history has to be pretty good, and there cannot be overlapping DNA mutations between the egg donor and the sperm source. So both the egg donor and the sperm source or sources will have their DNA mutations assessed. We all have them, but do not pick a donor with the same DNA mutation. And then, of course, what is her motivation and her desire? Your egg donor will come to our office for in-person medical evaluation. So first, we will take her history, where we go into her surgeries, her allergies, medications she's taking, and her lifestyle. The egg donor will have a psychological evaluation, as will the sperm source, as will the surrogate. The egg donor will speak with a genetic counselor because her genetics are very important. There may be some things in her history that the genetic counselor may say, okay, I think this is a red flag, and I just don't think this would be a good egg donor. When the egg donor is physically in our office, we will do a full physical exam that will also include a screen for drugs and infections. And then, of course, we will do all her egg tests, including an ultrasound of her ovaries. So once she passes all of that, you will finalize legal contracts with the donor, and then we rock and roll. So your donor takes medicines to make her eggs grow. The medicines are not pills. They are all injections. The needle is about 1 centimeter short, and she self-injects in the fat layer under her skin every day for about 9 days to 12 days. So about 10 days average. Now, this is an ultrasound picture of what nature does with our ovaries without any IVF drug. These small circles are follicles, but nature will pick one follicle to grow big, and this is the follicle that we ovulate. So an egg is inside the follicle. But if your donor takes these hormone injections, this is what we want to see. All these tiny follicles, all of them growing big, along with this one. And so you want to see many of these dark circles, not just one. That is the intention of these hormone injections. And the hope is that there is one egg in each follicle. And that's not always the case, but usually most follicles will have one egg inside. So while your donor is doing these injections, she will get these types of ultrasounds as well as blood work every few days. Finally, after the approximate 9 to 12 days of injections, she is ready to have her eggs removed. So the surgery is done in our office. We have a full operating room. She is put to sleep by an anesthesia doctor. While she's sleeping, I take the eggs out through the vagina. I do not cut her abdomen. And it's quick. It takes like 30 minutes. So what happens is, this is the uterus, this is the right fallopian tube, right ovary, left fallopian tube, left ovary, and this is the vagina. A vaginal probe is put in the vagina. And this line here is the needle. The needle is passed from the vagina directly into that black circle inside which is the egg. So each of these follicles will get poked by this needle. A lot of people think that we go this way through the uterus, through the tube. Not at all. It's a lot simpler than that. So in the ultrasound view, again, these are the follicles, the dark circles. This white line is the needle. The needle gets put into the dark circle and we evacuate the liquid. So here is a video of me doing a retrieval on an egg donor. So you can see this whole thing is the ovary and all these dark circles are the follicle. So the white line, my needle goes into the follicle. Notice the black circle is collapsing because I put suction on it to suck out the liquid. The liquid goes into a test tube. The embryologist has a microscope and looks to see if there is an egg, perhaps there is no egg. So you can see that it's pretty quick, fast surgery. So again, the needle passes into the follicle and just suck out. And that's why it takes about 30 minutes. Now, the day we take the eggs out is when we need the sperm, but we already have the sperm frozen. So all we have to do is thaw the sperm. If there are 2 sperm sources, we will divide the eggs in half and we will then thaw both sperm sources and they each will have their own cohort of eggs. So the way we put sperm into an egg is called ICSI, I-C-S-I, intracytoplasmic sperm injection. So fertilization in nature occurs occurs by natural selection. Here is an egg, and you have millions of sperm surrounding an egg, of which one sperm will enter the egg. But the way we fertilize through IVF is called ICSI, where we manually put one sperm into the egg. So here's a video of ICSI from our lab. So here we cut the tail of the sperm so it stopped moving. Then using a pipette, we grab the sperm by the tail. So when we select the sperm, we look for sperm that has a normal shape and that is moving. And it is for this reason that we don't need perfect sperm. We just need to make sure you give us enough sperm so we have a pretty good selection to choose from, but it doesn't have to be perfect. We then move to the dish that has the egg. Now this is a pipette that will hold the egg in place, so when we put the sperm into the egg does not move. Notice the difference in size between the egg and the sperm. It's quite remarkable. So we're positioning the egg just so that we can get the sperm in. This is the pipette that has the sperm. And now it's piercing the egg. Here's the sperm. We withdraw some liquid. Here comes the sperm. And that is ICSI. And that's just one egg. So can you imagine if we have a donor from whom we got 32 eggs, and on that day we have 8 cases, the amount of time and skill level that goes into doing ICSI. And it's for this reason we have about 12 embryologists in our office who work in shifts. They are the first people to come to the office and the last people to leave at the end of the day. Once the sperm and egg come together, it's fertilized. A fertilized egg we call embryo. That embryo is then grown in the lab 5 to 6 days. But why? Well, why do we get 5 to 6 days? Because in the female body, this is the fallopian tube, here's the ovary. When we ovulate an egg, the egg leaves the ovary, goes into the fallopian tube, and eggs just sit there waiting for sperm. Well, sperm comes up the uterus through the tube to go meet the egg here. Sperm and the egg meet at the very end of the tube to create an embryo. Well, sperm gets to the egg in seconds, but this embryo takes 5 to 6 days to travel the length of the tube to be the right stage of development to stick in the uterus. So that's where we got 5 to 6 days from. We just copy nature. And during that time, the embryo goes from 2 cell, 4 cell, 8 cell. And by the time it gets 5 to 6 days, it has over 100 cells. So this is a picture of an embryo that's fertilized. You have 2 sets of chromosome, one from the egg, one from the sperm. By day 2, it should become 2 to 4 cells. By day 3, it should be about 6 to 8 cells. By day 4, it compacts. And by day 5, it opens up to become this fluid-filled cavity called the blastocyst. And sometimes it takes 6 days to get here, and that's okay too. But here's what's important to keep in mind. Not every egg inside which we put a sperm survives this 5 to 6 days process. So it's like an upside down triangle. You start with this many eggs, this many fertilized, and this many survive the 5 to 6 days. There's an attrition rate that happens. But of the eggs that survive, of the embryos that survive, we then freeze them. But before we freeze, we have the choice of a test called PGT-A, pre-implantation genetic testing-aneuploidy. And what this is you can biopsy the embryo to look for 2 things, number of chromosomes and the sex of every embryo. So earlier I talked about DNA mutation testing, and this is a little bit different. This is not looking at the DNA mutations. This is simply counting number of chromosomes. So here we have chromosomes 1, 2, 3, 4, 5, all the way to 23 in 2 copies. 1 copy came from the egg, 1 copy came from the sperm. So 23 is a total of 46. If you look over here, notice that chromosome 21 has 3 copies, not 2. This is your classic Down syndrome, trisomy 21. But PGT-A doesn't just look at 21. It looks from 1, 2, 3, 4, 5, all of them, all the way to chromosome number 23. Now, the 23rd chromosome is a special chromosome. It is the sex chromosome. In this example, it has an X chromosome and a Y, as does this, X and Y, and that means it's a boy. If it was XX, that would be a girl. So in PGT-A, you also will know the sex of every embryo, so it's okay to tell us your sex preference. Here's a video of the PGT biopsy done in our lab. So this whole thing is the embryo. We take the biopsy of the outer ring called a trophectoderm, which becomes the future placenta. So the biopsy actually isn't taken out of part that will become the baby. It's taken out of the part that will become the placenta. 1%. This red dot is intentional. This is our laser. So we use lasers to cut the cells, and we take out about 4 to 6 cells. A common question I get asked is, oh my goodness, what's the damage rate? Believe it or not, it's less than 1%. There it goes. Okay, so now you have your embryos, you have your PGT results, which means you're ready for part 3, transfer into a surrogate. So ACRC, again, will present you potential surrogate profiles. And if you find somebody that you feel like, wow, I really like the profile that I see, our job is to make sure she's medically appropriate. So there are some surrogate criteria, and these are set by our national organization called the American Society of Reproductive Medicine, ASRM. Number 1, age of 21 to 45 years old. Now, that is ASRM criteria. Personally, I'm not so keen on a surrogate who's 45. I would prefer that she's under 40. But I have worked with surrogates who are 40, 41, and as long as they are otherwise healthy, I'm completely fine with a surrogate who's 40, 41. But personally, not so keen on a 44-year-old surrogate. She must have had at least 1 uncomplicated pregnancy, 5 or less deliveries, 3 or less cesarean sections. She must have a stable family. And of course, her motivation and desire are important. And ACRC, of course, will interview her to glean this information. Now, our clinic has a weight criteria, our body mass index of under 32. And if your surrogate does not meet that BMI criteria, we will wait until she loses the weight. And after then, can she then prepare her uterus for the transfer? Your surrogate will come to our office for in-person evaluation. We will take her history and, of course, her pregnancy history, her lifestyle choices. She also needs psychological evaluation. And in her physical examination, we will make sure that she's healthy, drug screened, infectious diseases, and her uterus is normal. The uterus test is a test called a saline sonogram, where we put water into the walls of the uterus. We want to see this beautiful, smooth wall. What we don't want to see is this in the uterus, something growing in there. But if we see that in the uterus, it's okay. She needs a simple surgery called a hysteroscopy, quick outpatient surgery, not even an hour, where an instrument is put in and this is removed. So she still can be your surrogate. She just needs a little surgery before she does that. Once legal contracts are received, we roll. So her medicines are hormones of estrogen, which generally we use estrogens by mouth. And the progesterone, we generally use progesterone injections, big needles in her butt. And if she's pregnant, it's every day for 3 months. What we are hoping to achieve with the estrogen shots is a nice thick lining in her uterus. We want the thickness from here to be at least 8 millimeters thick. And we want this pattern of 3 white lines. Boom, boom, boom. We call that triple layer pattern. Once we see this, then she can start her progesterone injection. For the embryo transfer, your surrogate is wide awake. It takes 10 minutes. It's pretty quick. So while she's awake, I pass a catheter into the uterus and drop the embryo in here. Now, usually we will transfer 1 embryo. I am one of the few doctors left that will transfer 2 embryos at the same time. Here's a video of me transferring into a surrogate. This whole thing is the uterus. Okay, that's the catheter. So I'm talking to her. She's wide awake. Keep your eye on the tip of the white line. A pretty quick procedure, right? And very painless, which is why it takes about 10 minutes. 12 days after the embryo transfer, your surrogate will do a blood test to confirm she's pregnant or not. So most surrogates don't live here, so many of them will fly here. It's very common. When we do the embryo transfer, the next day she flies home and she doesn't come back to our clinic. So all of these pregnancy tests, the ultrasound, the blood work are all done in her hometown. So 12 days after the transfer, through a blood test in her hometown, we find out if she's pregnant or not. And if she's pregnant, she's already 4 weeks pregnant. 2 weeks after this blood test, she will do an ultrasound. So at 6 weeks and then another one at 8 weeks to make sure that the baby is in the right place and that it has a heartbeat. So this is what we're looking for. This whole thing is the uterus. Inside the uterus, there is a black circle called the gestational sac. Inside the gestational sac is a white ring called the yolk sac. And this right there looks like a little smudge is the baby. And you should be able to see the heart beating at about the 6-week mark. And if it's sort of, I'm not so sure I see it, well then for sure by 7 or 8 weeks, you should see a heartbeat. Now, if I put 2 embryos in and they both implant, what you should see is this. So this whole thing is the uterus, but inside you see one black circle and another black circle. And inside each black circle, you see there's a little circle, the white circle called the yolk sac, and here's the little smudge. And here's the little white circle, the yolk sac, and there's a little smudge. So one baby, two babies in two very separate cavities. Through the process of IVF, there is a 3% chance that an embryo can split and be a set of look-alike twins. So that is here. This is the uterus. And notice there's only one black circle, but inside that black circle, you have one yolk sac, another yolk sac, and here's your little kronrumpling, the little smudge, and here's the other little kronrumpling. So one sac with two babies inside. This is one embryo that's split. So that's what the ultrasound will show you. We will then remotely take care of your surrogate until she's 8 weeks pregnant, so 2 months. And then after that, her obstetrician takes over and delivers your baby. So I hope that this talk really helped to organize the egg donor surrogate journey in a way that's easy to understand, very organized, and not overwhelmed. So thank you so much for your time. Should you have any questions, feel free to email me at spark@sdfertility.com. And this is my son who's now 10.
Thank you so much, Dr. Park. That was amazing. Absolutely amazing. Loved it. I love the videos too. Very detailed, very intricate. That was good. That was so good. So going into the next part, we are going to jump into the raffles. So I'm going to share my screen one more time so that I can pop this part up here. And we can just quickly get that scanned, go ahead into that part. And in the meantime, Dr. Park, I'm going to have you be a participant. If you can choose a number between 1 and 10, as we have 10 attendees, and they all have a number. So if you just choose a number between 1 and 10, you'll be choosing one of the attendees.
All right. I will pick number 4.
Okay. Number 4 is going to be Tingny Tang. Okay, so that is 725577. All right, you won the $1,000 credit. We will go ahead and reach out to you, email you with that information. Congrats. Give you a go ahead and round of applause. Yes, big congrats. So yeah, we'll send you that information and get you that $1,000 credit. Amazing. Again, congrats. Now we can jump into questions because there are quite a few here. So let me stop sharing. Second. Okay, so the first question for you is, why do some eggs not survive?
Great question. So there are different points where it doesn't survive, right? So one is, why don't follicles respond to the medication? Why, when we go in for retrieval, are some follicles empty? Why, when we get some eggs, we look and we got an egg, but it's not mature? Because you can only put sperm in mature egg. Why, when we put sperm into an egg, does it not fertilize? And a lot of it is, there's so much about the egg that we don't know. But a lot of it, honestly, is driven by egg quality. What drives egg quality? Your age. So in general, the older a woman gets, not only are there less quantity of eggs, there's also lower egg quality. So it happens. I mean, in my 20 years, I've seen a lot. I've had egg donor cycles where it's just been bad, but you don't often see that with egg donor cycles, but I have seen that a lot with women who are older. And if you are older, my advice to you would be, if you don't feel ready to close this chapter in your life, keep trying multiple cycles, maybe different protocols. There's no guarantee a different protocol will yield a different outcome, but I have changed different protocols and seen a different outcome, but not always. But that would be my advice if you've gone through IVF and you did not have great egg quality.
Okay, great. Next question, can we do something to ensure more eggs survive?
Again, depends on your age. So you can try to change the protocol, but no, at the end of the day, if you're older and your egg tests are okay, or maybe they're bad, honestly, there's really not much you can do. I mean, there's a lot of the internet. For example, there are supplements and acupuncture. People talk about PRP. And I would say if you want to try all of that, by all means, but the scientific data showing that how effective they are, it really is hit or miss.
Okay. On average, how many eggs do you try to retrieve per cycle?
So unlike guys who make new sperm all the time, we women do not make new eggs, right? You were born with all our eggs. And every month, your body will activate a group of eggs. And that group has a name. They're called antral follicles. So let's say your body activated 10 antral follicles. Then naturally, your body picks one of the 10 to grow big and ovulate, and the other 9 die off. If your body activated 3 antral follicles, then one of the 3 will naturally grow big and ovulate, and the other 2 will die off, okay? If you give somebody IVF drugs, drugs, the intention is to not let them die off. So for that patient who activated 10 antral follicles, if I give her IVF drugs, I'm hoping for 10. For the woman who activated 3 antral follicles, I give her IVF drugs, I'm hoping for 3. But you cannot have an antral follicle count of 3. I give you IVF drugs and you're hoping for 30. It doesn't work that way. The IVF drugs don't change what your body activated. Your body says, this is what you have to work with, and that is it. So the advantage of an egg donor is the younger we are, the more antral follicles we activate. So again, the IVF drugs aren't changing the antral follicles. Your body says, this is your potential. The IVF drugs are just helping you reach your potential. But if your potential is low, the IVF drugs will result in low number of eggs because your antral follicle count number was low.
Okay, got it. Where does SDFC store their eggs?
Oh, good question. So there is a smartphone for incubators. It's called a Tomorrow Machine. We were actually the first center in the United States to have it installed. So it has all these sensors. It's like your phone. It tells you, right? Or your thermostat at home. It's like the same thing, but for an incubator. So our initial intention was to be a long-term storage for our patients, but we quickly realized we were running out of room. So we hold on to it for 4 years, and then we do send it off to long-term storage.
Okay, nice. I mean, that sounds really cool, actually, like a smartphone incubator app.
Yeah, it's actually a really cool machine.
Nice. Okay, so the next one is are there any lifestyle changes that you would recommend making prior to egg freezing?
Well, again, nothing has been proven, but I'm a big believer of healthy lifestyle, right? And you need to be honest with yourself. Do you eat out a lot? Do you eat a lot of junk food? Do you drink soda? None of that is good for you. So I'm a big believer that you need to look at yourself. You need to make sure, am I eating healthy? Am I exercising regularly? Am I getting enough sleep? What is my stress level like? I try to cook a lot at home and focus a lot on antioxidants. That's really, really big. And there's so many books out there that talk about supplements, and I would absolutely consult with a fertility acupuncturist. They're really knowledgeable about supplements, knowledgeable about tests that you can do that have nothing to do with egg tests, but just more about vitamins, etc., just to make sure you're as optimal as possible.
Okay. Is there any blood work or other tests that you should get to see if you're a good candidate for egg freezing or IVF?
So for sure, there are 3 egg tests. Number 1, a blood test called anti-Mullerian hormone, AMH. This is a hormone made by the eggs in the supply, which we cannot see. The AMH can be done any day of your menstrual cycle, okay? Then there's another blood test called follicle stimulating hormone, and you should do that with an estradiol level. Now, this blood test should be done on the 2nd, 3rd, or 4th day of your cycle. The 3rd egg test is an ultrasound to look for the antral follicle count, AFC. That can be done any day of your cycle, and that looks at how many eggs your body activates per month. And the number, sure, there's slight variation, but it doesn't vary drastically. So if you get an antral follicle count, it kind of gives you an idea of, oh, okay, this is approximately how many eggs I will get should I decide to freeze my egg.
Okay. Should you wait to schedule your initial consultation until you're ready to start the process, or is it better to schedule the initial consultation ahead of time?
It depends. So if you're pretty young, maybe you want to wait. But if you're maybe I would say in your 30s or older, you may want to schedule the consultation at least just to get your status, right? Figure out egg-wise where you stand. And then if you realize your numbers are amazing, you may feel, okay, feel less stressed, I feel reassured, I feel better. Maybe I'll wait a year.
Okay. How long can frozen embryos be stored?
Oh, good question. Indefinitely. And I know this sounds crazy, but the quality does not change. So whether frozen embryos are stored for 2 years or 20 years, the quality remains the same. And it is for this reason that people will do what we call fertility preservation. They know they're not ready to have kids. They make these embryos and freeze them. And then let's say 8 years later, they're ready to have children, but their success rate remains the age they were when the eggs were removed, not the age they were when they are receiving these fertilized eggs. Now, for frozen eggs, it's very similar. The only difference is frozen eggs, meaning you froze these eggs unfertilized. When we take the eggs out of the freezer, the survival rate nationally is about 70 to 80%. At our clinic, it's probably closer to 90. So when you thaw the eggs, you may lose a few eggs just because of the freeze-thaw process that otherwise, had you fertilized them fresh, you would have been able to put sperm in them. But because you froze them and you defrosted them and the few didn't survive, you could have put sperm in them. But the egg quality should still remain pretty good over the year.
What are some major differences between freezing embryos and freezing eggs?
So in freezing eggs, because I did not fertilize, and then later when you come to thaw, a few may not survive thaw process. Like if you had this many eggs, you may then, when you're ready to fertilize, have this many eggs to start the fertilization process. Versus if you're freezing embryos, I got this many eggs from you and I can fertilize this many eggs because you fertilize them all fresh. My advice to you would be that if you are single and you're really not sure who your future partner will be, by all means, freeze your egg. But I have a number of people that come to me and they have a male partner, but they may not be married, but they feel pretty certain this is the person they want to spend their life with. Then I'd encourage them, if you're sure this is who you want to spend your life with, then fertilize your eggs and make embryos. Another option people take, because maybe they're dating somebody and they're kind of not sure. Another option you can take is you can do a split. You can take your eggs and say, hey, can I fertilize half and freeze the other half? You can do that. But I caution you that you better be sure you've got enough eggs, right? Because if we have 15 eggs we got from you to fertilize 7 and leave the other 8 frozen, it's okay. It's not great. But if I got 34 eggs from you, oh my goodness, that's just a lot of good ones that you could freeze and fertilize. So I wouldn't suggest doing that split cycle unless you really do have a lot of eggs.
Okay, that's really good advice. I like that. So how and when do you destroy eggs and embryos if they are not used?
Oh, okay. So we keep, even abnormal embryos, we keep them frozen. You have to put it in writing. So there's a form you have to fill out and you have to submit it in writing in order for us to destroy it, if that's what you want.
Do you need to have your ultrasound on the first day of your cycle, or can you do it in the middle of your cycle as well?
I believe you're referring to the ultrasound for the antral follicle count. So that one can be done any day of your cycle. It doesn't matter.
Okay. Are there any concerns with shipping eggs elsewhere?
Yes, but the risks are small. So there are companies that specialize in shipping eggs, sperm, embryos, and we can certainly give you information on those companies. And those companies offer different packages, from the most personal, where a person literally carries your tank that has your eggs, sperm, or embryos and puts them with them on the airplane, etc., to where you can just get them shipped. So there are a lot of options available to safely transport. I haven't had any issues with domestic transport. I have had issues with international embryos, and they both came from Asia, where the liquid nitrogen tank just didn't do its job and the specimen came already defrosted. But it's, believe it or not, I mean, it's in my 20 years, for me personally, it's happened twice. So it's not that common.
Okay. Can you speak on how PCOS or fibroids can make egg freezing or IVF more challenging?
So PCOS, just so everybody knows, is polycystic ovarian syndrome. And in simple terms, this is a condition where a woman is born with an abundance of eggs. However, PCOS eggs are not always the best quality. Okay? And keep in mind that because you have a lot of eggs, when you do take the IVF injections, you will have a lot of follicles responding, which means that your hormone levels will rise higher. So you're at increased risk for just getting super bloated after the retrieval. But not all the follicles will necessarily have eggs in them. So this morning, I had a retrieval in a PCOS patient. In our last ultrasound, we estimated around 40 follicles that were big, and I ended up getting 28 eggs. And I said to her, I understand you have a lot of follicles, but you need to understand, especially with PCOS, not all the follicles have eggs in them. And from the eggs we get, not all of them will be good quality. Okay, so one is really egg quality with PCOS. 2, because of your quantity, just brace yourself that after the IVF, that recovery will be longer because you will just be a lot more bloated. As for the fibroids and egg freezing, generally it's not a problem, with one exception. Generally, fibroids, they're located all over the uterus. And generally, they're not near the ovary, but sometimes they are. So when you have an ultrasound to look at your ovaries, you will know, because if your ovary can easily be seen and it's very near the vaginal wall, you'll be fine for an egg-free cycle. But if your fibroid is, especially if it's big and bulky, and it's like, oh, you got to get around it to go see the ovary. Yes, I have peers who've gone right through fibroids to get to an ovary. Yes. But sometimes you can't because that fibroid is so dense. It's always better to go around a fibroid to get to the ovary. So just keep in mind, depending on the size and the location of your fibroid, if it is very adjacent to your ovary, you may not be able to have every single follicle evacuated.
Okay. Do you advise transferring multiple embryos to increase the odds of success?
Okay, great question. So 20 years ago, when I started my career, we never put in one. Our IVF success rates were so bad that we always put in 3, 4, 5. It was just the norm. Over the years, so many advancements in our field have resulted in such amazing success rates, right? So now when we transfer an egg donor embryo into a surrogate, our implantation rate is 75%. I mean, it's huge. Okay, so right now the advice is to transfer one, but there are many people who advise to transfer two. So here are the risks. Number one, not all surrogates want to carry two. So when ACRC is finding a surrogate for you, a surrogate may say, oh, they want me to accept two. I'll pass on them. Who else do you have? Medical screening, we are stricter with surrogates who can potentially carry twins. If I transfer two, there's no guarantee of twins. Half the times when I put in two, there's one embryo. Keep in mind, remember I mentioned earlier the 3% chance of an embryo splitting, right? I put in two embryos. What if they both implant and one splits? All of a sudden you have triplets. Not great. Okay, triplets are very risky. But let's say your surrogate is pregnant with twins. She's at higher risk for diabetes, high risk for blood pressure issues. And of course, they will medicate her, but if the medicines don't control her, your twins will be prematurely delivered to save her life, even though your twins are not ready to come out. And then, of course, premature delivery is the scariest, right? Because nothing is ready. Heart, brain, lung, intestines, nothing is formed. So your twins will be in the neonatal intensive care unit. We call it NICU. And depending how early they come out, they may not be fully developed. And that then has immediate medical concerns in addition to long-term potential medical complications, such as high risk for autism, high risk for learning disabilities, etc. So the decision to put in one or two is not a decision to be made lightly, but I inform every intended parents of the pros and cons. The reason why I still do it is, in my opinion, you're not a child, you're an adult. It is my job to educate, your job to make the decision. And I will support your decision as long as I realize that you are making an informed decision.
I love that. Okay, two more, and then we can wrap it up. Okay, I know we have questions that are constantly like coming in. I'm like, ah. Okay. Does diet, supplement, lifestyle really have any effect on the egg quality, or is it just something that is age related and it's a two-parter? And if so, does tea or caffeine affect the quality of the egg as well?
Okay, so at the end of the day, it honestly is age related. I mean, that's the honest truth. Okay, however, I think every woman should do what she can to optimize, right? You cannot change your age. I mean, time is what it is, but you can at least do your part. So I truly believe that if a woman eats a lot of junk food, doesn't exercise, doesn't take care of herself, I feel like you're putting yourself behind the eight ball, right? Put your best foot forward, right? Look at your lifestyle and say, I cannot change my age, but I can at least do my part to do the best I can. And this is really where supplements come in. Our fertility acupuncturist, I think, would be helpful to consult with them and say, hey, what supplements would you advise? Okay. And then the other part is tea and caffeine, tea and coffee. There's no study confirming that tea and coffee affects your equality. However, I think a good rule of thumb is everything in moderation. Okay. We know that when women are pregnant, you should have 300 milligrams of caffeine a day max. My mentality is, why? Do you really need to have your caffeine when you're pregnant, right? But again, the idea for that is everything in moderation. So same, I know you're not pregnant, you're trying to get pregnant, but really, do you really need 3 cups of coffee a day? Is that really so healthy, right? So I think you should really look at your lifestyle and say, okay, well, maybe I'll reduce myself to 1 cup of coffee a day, or maybe do a mix of caffeine and decaf because you really enjoy the flavor of coffee.
Okay, and last question. How long do you have to wait between egg freezing cycles? Can you do it back to back? Month to month?
So generally, it would be about a month. So let's say you had your retrieval today. You will get your period within 2 weeks. You can start with your period, the pre-IVF hormones to prep your body. Now, not all fertility clinics use pre-IVF hormones. We do, meaning when you get your period, you get on a pre-IVF hormone, the type of which is based on your egg test result. But you do the pre-IVF hormone because that tells your cycle, hey, don't pick a dominant egg. Everybody just stay very quiet. And you're on that for a few weeks. And then we tell you when to stop it. And then bam, you start your IVF drugs. So your eggs leave the gate synchronized. That's the idea behind the pre-IVF hormone. So if you had a retrieval today, you get your period, right? Then we usually have you start at day 2 or 3 of your period. You start the pre-IVF hormones, but you're going to be on it for a couple of weeks before you stimulate again. So naturally, your body has actually taken about a month break. So that's our advice, that you wait at least a month. Now, when you are ready for your next cycle, you will have a baseline ultrasound and blood work. And on that baseline, we look at your ovaries, and the blood work will test the hormone levels, and it will tell us, oh yes, everything is back to baseline. Thumbs up, you're ready to go. If however, on baseline, I see, oh, wait a minute, she still has these remnant follicles that haven't fully collapsed from her past IVF cycle, then I'm going to say to you, we're no go. Sorry, your body is saying, I need more time to relax and to recover. And then I will say, let's do this again the following month, or maybe give you a few weeks, but you can't do it now.
Okay, amazing. Thank you so much, Dr. Park, for answering all of those questions.
You're welcome, Rocky. This was fun.
Yes, it was. It was. And I'm going to share my screen one more time. I know I keep saying one more time, but this is the last time. I promise. I promise. Okay. So, again, I just wanted to go ahead and show everybody that you can scan this QR code for a free consultation. Of course, Dr. Park gave you a whole lot of information to kind of mull over this weekend. So please take your time, get into that, but definitely jot this down or take a picture, take a screenshot, whatever you need to do, and get in touch. Get in touch with us so that we can help you figure out your process, where you want to go in this journey, where you are in this journey. Also, we have Dr. Park's information below, so please get that, make sure you have that. Yes, her email is provided below. So again, this was the webinar featuring Dr. Park and SDFC and her amazing knowledge and expertise. If you would love to schedule a consultation with us at ACRC, again, you can scan that QR code provided on the screen here. But other than that, we can enjoy the rest of our weekend, get into whatever we want to do. It's looking nice and sunny over there. I'm a little jealous, Dr. Park.
It is.
Not gonna lie. I'm not gonna lie. It's just a little jealous. I'm a little jealous. But I'm living through the moment. I'm living through the screen. So thank you for even providing that little sunny moment behind you. Okay. Thank you. And
You're
again, as
welcome.
always, it was a pleasure. So thanks.
Same here. Thanks, ACRC. And